education session is sponsored by CancerNet. To receive a CMA and CE certificate, please complete evaluation by April 18, 2026. This is a disclosure of unlabeled use. So I'm Ken Yang. My colleague, Dr. Chiheda, will join today's education session. This is our disclosure. The learning objective today, number one, is to summarize the classification of DLBCL, molecular features, genetic subtypes, risk stratification, and upfront regimens. Dr. Chiheda will be presenting to assess a novel therapy for refractory-resistant DLBCL by using ADC, CAR-T, bispecific antibodies, and combinations. And both presentations will be 30 minutes in each, and we will have pre-test poll and post-test poll in each of these presentations. So let's start with the first one, pre-test clinical questions. Which of the following panels of biomarker studies will be helpful for molecular subclassification in DLBCL? So we have 5 different options, that including CD3 T-cell markers, CD20 B-cell markers, CD10, BCL2, BCL6, MUM1, MYC, KL67, or PAS5, or FOXP1, or CD30, or EBV. Which will be your best options? Yeah, so, okay, good. So let's start with the first presentation. I'm going to share with you regarding the DLBCL and the high-grade B-cell lymphoma about the current WHO or ICC classification, molecular characterizations, genetic subtypes regarding the risk stratification, and touch a little bit on upfront regimens. So my presentation will touch each of these 5 major components regarding the precision diagnosis classification, risk stratification, prognostic and predictive biomarkers, and propose important biomarkers that may be actionally alterations for therapeutic decision-making process. And microenvironment will be also critical, maybe associated with related immunotherapy. This slide shows you regarding the B-cell differentiation. The B-cells coming from bone marrows and migrate into the blood through lymphoid tissues for maturation into differentiate into the plasma cells. So the lymphomas B-cells that could be arising from each stage of the B-cells. Now, the most common, today we're going to touch the DLBCL, could be arising from germinal center B-cells, could be also coming from outside the germinal centers that commonly we call the activated B-cells from peripheral blood or surrounding soft tissues. Now, the other B-cell lymphomas could be fell into low-grade or high-grade or Hodgkin lymphomas. They may arising from the same cell origin, same stages, but they may present it with a different pathologic, phenotypic, and the clinical features. We can roughly divide B-cell lymphoma into low-grade and high-grade. Today, I'm going to only focus on the DLBCL and primary misdiagnosed and high-grade B-cell lymphoma. Now, this category probably representing one of the most common B-cell lymphoma in the United States and European centers. Those are probably around 30 to 35%. The second most common is the follicular lymphoma. So all the B-cell lymphoma, probably around 80% of all the lymphoma categories. Now, in the United States, T-cell lymphoma is relatively uncommon. Hodgkin lymphoma is around 15%. It's quite stable in any countries in the world. When we look in the DLBCL and high-grade B-cell lymphoma, we usually include 5 major subtypes. DLBCL is the most common one. And based on cell origin GCB ABC, in the United States, we see around 35,000 new patients per year. And coming together with recurrent patients, probably representing 150,000 patients in the United States. The second type is called high-grade B-cell lymphoma, around 4,000 patients per year in the United States. The other subtypes are relatively uncommon, including NOS, Burkitt, plasmablast lymphoma, or mediastinal cell lymphoma. Those come together probably around 3,000 patients. So as we see here, the DLBCL representing the most common B-cell lymphoma in the United States and in any countries in the world. So we are facing this population disease that is become a major clinical focus. When we look at epidemiology in the United States, we probably see all the lymphomas around 75,000. Of those, 30% are DLBCL or high-grade B-cell lymphoma. The death rate is around 30%. Now, the frequency of DLBCL is higher than any other hematological malignancies, including AML, MDS, CLL, T-cell lymphoma, or myeloma. So myeloma frequency dramatic increase, probably comparable to the frequency of DLBCL. Now, the median age in DLBCL is around 69 years old. As we see a curve, it's relatively uncommon in pediatric population, but after 75, the disease frequencies also decrease. So this figure shows you the frequency distributions of disease in the United States. Based on this major challenging in the hematology field, WHO and ICC developing a classification algorithm. Now, this is based on the 2017 classification. In 2022, international consensus classification, we call the ICC. WHO continues with the current new classification. So these two classifications may show in slight difference in regarding the DLBCL and the high-grade B-cell lymphoma. So we like to see that both committees can reach consensus in the future to support in the future classification based on cell origin, phenotype, molecular features to support a better clinical management. This table shows you the comparison regarding two classification committee in DLBCL. As we see here, we reach a consensus regarding the cell origin, GCB or ABC, no questions. Burkitt lymphoma, no changes. Now, the primary CNS testis in the ICC remain to be separate, while in WHO put into a category called the primary large B-cell lymphoma of immune privileged site, including CNS, testis, vitreoretinal sites. So giving a general category, put the same together. The second difference is 11q alteration in ICC, still called large B-cell lymphoma, where the WHO put it into a high-grade category. Now, the third difference regarding the high-grade B-cell lymphoma in ICC, still including MYC BCL2 and MYC BCL6 as the two subtypes, while WHO only recognize MYC and BCL2. So the three differences present between two classification schemes that we need to pay a particular attention, reflecting the DLBCL or high-grade B-cell lymphoma, is quite heterogeneous regarding the location, cell origin, phenotypic features, and the molecular feature as well. So from clinical side, we're developing IPI index based on the 5 parameters to divide patients into 4 groups: low risk, high risk, intermediate risk. And those patients respond to treatment differently, and the survival is different. So we need to handling those patients based on the pathology, risk, and molecular features to decide how we're going to handling the patients. Now, this figure shows you if a patient is a high risk, less favorable for treatment, and those patients' survival will be much worse than favorable patients with low risk categories, suggesting that the treatment regimens maybe need to revise to individual patients based on clinical pathology and the molecular feature based on the treatment cycles and the regimen components as well. This slide shows you the treatment management need to be a long-term combination strategy, including transplantation, induction, and maintenance therapies, and how to handling the relapse settings. Dr. Chihara going to focus on many of those treatments and share with us his experience and the knowledge. But as we see here, DLBCL, same as many other cancers, they all relapse is inevitable. So we, in the initial phase, on the upfront regimens, we emphasize maximal response, fast response, to minimize MID residual tumor in the body. Whereas long-term, we emphasize improving patient PFS and OS, preventing disease relapse, extend the duration of remissions, improve patient quality of life. So in the patient in-high journey, we need to be follow this strategy. This slide shows you the rough strategy regarding the first line, second line, and third line. As we see here, the first line has been expanded based on patient treatment response. Whether it's early relapse or primary resistant, we can decide whether it's CAR-T or bispecific antibody. If a patient able to achieve good CR/PR, transplantation or other regimens could be benefit to the patients. For the later relapse patients, we have many different options available to handling those patients as well. So the treatment strategy could based on clinical pathology molecular features But from this, we still can see there are many unmet clinical needs in managing DLBCL patients. This can come from clinical features, could be coming from patient treatment response, molecular pathology, genetic features as well. We particularly focus on 5 groups of patients, including double hit, double express, ABC subtype, elderly patients, or high-risk patient category. So all those patients represent different percentage of patient response to current standard of care with a different response rate. The 5-year survival or PFS or OS relatively lower compared with other subtypes. Emphasize there are many spaces that we need to make improvements. So in the recent 10 years, there are many new therapies moving into the field, now including ADC, monoclonal antibody, bispecific antibodies, cell therapies, including some small compounds. Those combinations may render a better outcome for the patient. When we're managing DLBCL patients, we also emphasize the patient's journey, from initial management on the patient diagnosis classification into monitoring patient treatment response, to follow patient surveillance, monitoring patient treatment response, achieve complete remission or partial remission, or patient may show disease progression. So our management on patients need through the entire patient's journey. So on my lectures, I would like to focus on the pathology part. Now we emphasize collaboration between pathology and the clinician and the hematologist to improve patients' judgment, management, and the monitoring process. Particularly emphasize 7 points: diagnostic accuracy, useful risk stratification, and subclassification, prognostic predictive biomarkers, and help our colleagues developing effective treatment, monitoring patients by using unique or companion tests, supporting patients for advanced immunotherapy, cell therapy, even future clinical trials. So when you're looking at pathology, DLBCL, there are 6 different patterns. These are normal lymph node structures, could be central, could be peripheral. So DLBCL can present with a diffuse, nodular, or with limited involvement, with a background of histidine proliferation, extensive necrosis, or lymphocyte depleted pattern, or focally sinusoidal involvement. So different patterns sometimes could cause a confusion regarding the diagnostic accuracy. So let me share with you some of the pathology figures. Diffuse pattern, no question, is easy to make a diagnosis, extending involving the major tissues. Sometimes the nodular pattern, this could be primary, could be secondary. Most commonly could be transformed from previous follicular lymphoma. From the cytology, could be monomorphic tumor cells showing quite homogeneous in size and appearance. Could be polymorphic with a different size, different irregularities regarding nuclear cytoplasmic features. Could be polymorphic, the background containing many inflammatory cells, eosinophils, histocytes. Sometimes the DLBCL can present with uncommon pattern. For example, this patient showing intrasinusoidal pattern. These lymphoma cells present within the sinusoidal structure, CD20 positive. They are positive for BCL6, MYC, p53. So those patients commonly presented with ABC subtypes showing poor clinical survivals. So when you're making diagnosis, there are many pitfalls we need to be careful, because the biopsy tissue could be containing fibrosis, necrosis, many reactive normal cells, vascular proliferations, or granuloma. And those may become a major part of the biopsy tissue, while the DLBCL tumor cells could be only a small portion. So we need to be extremely careful on those. Let me share with you some examples. This patient showing extensive fibrosis. The tumor cells individually distributed behind these fibrotic lesions. Necrosis. This could be lymphoma necrosis, right? Could be avascular necrosis. The most of the tissues are reactive lymphoid cells. Could be a background loss of inflammatory cells, including granuloma lesions. The lymphoma hidden behind it, right? This slide I share with you extensive fibrosis in the mediastinal mass, whereas the lymphoma cells are mixed with normal small lymphoid cells, and those is easily to be missed. We need to rely on the biomarker study to help us. Sometimes the tumor proliferation is very high, causing necrotic changes. This will limiting our diagnostic accuracy because many biomarkers will be not useful. Now, some patients contain extensive granuloma lesions. These are chronic inflammation from the patient with a background autoimmune disease or inflammatory disease. So the lymphoma cells could be present in focal area. We need to be very careful. So besides of these confounding factors, DLBCL diagnosis could be some uncommon type. They could be present in very unusual anatomical locations, could be with a different pathology pattern or biomarker patterns. Let me share with you some of the cases. For example, primary cutaneous DLBCL leg type. They could be present with extremity mass lesions. They could be present in the brain with very limited areas, and those tumor cells mixed with brain cells with vascular proliferation and stromal cell proliferation. Sometimes lymphoma could be only present with small vessels, and those very easy to be missed. Now, few lymphoma cells will present with very unusual biomarker. For ALK, we know those ALK is positive in the T-cell lymphoma, but it could be in 1% of the DLBCL, and those patients present with relatively poor survival. And the T-cell histologically rich DLBCL, the lymphoma cells only comprising 1 to 3% of the entire lesion. Most of the cells are normal reactive cells, and this is also easily to be missed and causing diagnostic challenging with Hodgkin lymphoma as well. Can be present in unusual locations in testes. Those also are very unusual. The DLBCL also can associate with infections. For example, with HHV-8 infections, as a nuclear staining with HHV-8, could be associated with EBV infection. We call the fibrin-associated DLBCL, can be present in particularly in the pleural area, commonly seen in Asian patient population in Japan. And could be present in immunocompromised patients. For these patients with lymphomatoid granulomatosis, is EBV-driven surrounding the vessels. So the angiocentric lymphoma cells causing extensive necrosis. Those are also viral-driven process. Some of the lymphoma could be present in the mediastinal. So those is very uncommon, could be mixed with overlapping with Hodgkin lymphoma, could be overlapping with high-grade B-cell lymphoma, which sometimes we call the gray zone, with extensive fibrosis and necrosis. So from those challenging, the diagnosis we need to be more carefully. We need to using all the approaches, including morphology, biomarkers, FISH, and even targeted sequencing to help us to providing precision classification. So I emphasize 5 major points. When you're making diagnosis on DLBCL, we need to combine with clinical features, cell origin, etiology, whether virus infection is involved or not, and the molecular abnormalities, particularly MYC, PV3, BCL2, BCL6. And in the future, I think the single cell sequencing genomic thing will become part of standard practice. We're providing our colleague with a better judgment on the disease. So as we know, those mechanisms, why we need to doing those? The reason is providing our indications about the treatment response and the drug resistance. Those drug resistance could be coming from clinical features, could be coming from patient's host, right? Could be coming from pathology part as well, rendering patient primary resistance or secondary resistance with different mechanisms in the clinical course. So as we see here, DLBCL representing the most common one, we're based on the cell origin, but high-grade B-cell lymphoma is also a headache subtype. Now, they may share a common mechanism regarding the disease pathogenesis. For example, doesn't matter if it's DLBCL or high-grade. They could coming from germinal centers associated with many translocations, could be coming from ABC subtype associated with a particular specific B-cell signaling pathway abnormalities, could be coming from mediastinals related to PD-L1 JAK mutations. But regardless with the cell origin, they have a common pathway that associated with epigenetic dysregulation. And those particular pathways, we do not have any specific treatment has been developed targeting this pathway. So I predict in the future, and novel therapies may be developed in this area, including BCL6 degrader, could be in combination with current standard of care, render a better disease control. Let me share with you some of the molecular features in the patients. So my group did studies on 900 patients, analyzed patient based on cell origin. This table shows you single hit, single express, double hit, double express. What is the distribution in different subtype of DLBCL patients? As we see here, GCB patients, commonly showing high frequency of single hit, whether it's MYC or BCL2. No difference BCL6. While the protein expression, single expression, MYC or BCL2 much higher in ABC patients. Now the double hit only seen in GCB patients, triple hit only seen in GCB patients, not seen in ABC, while double expressed patients only seen in ABC patient with statistical major difference. So as we see here, genetic changes commonly seen in the GCB, whereas the protein phenotypic changes commonly seen in ABC patients. They showing different distributions, rendering patients with a different prognosis. As we see here, the combination MYC-BCL2 associated with the poor survival, same as the protein expression, but not MYC and the BCL6, not the BCL2 and the BCL6. So these results rendering the fundamental rationale for the ICC classification and the WHO classification. So the WHO only emphasize high-grade MYC-BCL2 because MYC-BCL6 is not associated with poor survival. However, double hit could have a different slight mechanism or clinical presentation. For example, double hit in 10% patients can present with leukemic phase. Those lymphoma cells can be circulating in the blood, extensively involved in the bone marrow. By using biomarker studies, we're demonstrating those particular DLBCL cells extensively involve the bone marrow with MYC-BCL2 double expression. Now, those clinical association in leukemic double hit associated with the bone marrow and peripheral blood involvement. With the double pass involvement, survival is worse. Whereas the double not involving the peripheral blood and bone marrow, survival is much better, right? So one involvement will be intermediate risk. So rendering our ideas, how we handling double hit patients, certainly we have different regimens, and those regimens should be replaced R-CHOP, because R-CHOP not render patient with a better control in the double hit events. Double hit can be also EBV positive. We're reporting 16 patients. This double hit could be MYC-BCL2, could be MYC-BCL6. They are EBV strongly positive. So propose a new idea in EBV positive double hit patients. They may represent different latency. So it's different from a traditional latency type 1, type 2, type 3. And EBV positive PBL double hit or HIV positive PEL, they're probably arising from resting memory B cells. They are latent zero without any EBV viral protein expression. Now, suggesting the DLBCL may associate with many viral infections that we need to pay attention. The lymphoma may associate the viral infection, may associate with bacterial infection, particularly in the HIV conditions. Many high-grade B-cell lymphoma may associate with HIV. Then we need handling those patients with a different strategy. Now, from aggressive B-cell lymphoma category, besides DLBCL, high-grade, we see around 4,000 new patients per year in the United States. And those patients usually presented medium-sized homogeneous cell population. And those patients sometimes can be overlapping, and they could have a single hit with unique genetic aberrations. And this category is still controversial, and we still have a challenging. So my group did studies demonstrating this group of patients, nearly 50% patients, containing p53 mutations. And by using standard of technology, we might missing 10% of double hit patients. So that we need to bear in mind that high-grade B-cell lymphoma, the DLBCL, they may share overlapping genetic and morphology pathologic features. They could be solid form, can be leukemic forms. And those particular genetic features, not only seen in DLBCL and high-grade, sometimes we can see in ALL, AML, or Burkitt lymphoma as well, indicating the molecular studies need to move into a relatively deep levels. So based on the cell origin, NIH combine all studies in nearly 600 patients, divide based on genetic features into patient 7 group based on the different molecular features. Each group may represent different signaling pathways. In the ABC patients, as we see, most common would be MCD, BN2, whereas the GCP patients, most common would be ECB subtypes. So based on this classification, we're able to move up into next stage and how we're going to treat the patient in a much better way. So for example, if we only base the cell origin, the excellent studies, POLARIX studies, by using POLA plus RCHP, you can improve patient ABC patients, improve their clinical OS PFS, but not changing in the GCB patients. So this is a major progress made based on the cell origin. But if we combine cell origin and genetic mutation NGS analysis, maybe in each subgroups, we're able to design different treatment and improve patients for precision management. Why are we saying this? Because each group may represent different genetic features. For example, in MCD patients or BM2, let's look in the genetic features. MCD BM2, they are very rich in B-cell signaling pathway mutations, including MYD8879B, HIM1, and PRDM1. And those patients, if we have those mutations, they might be response to BTK inhibitor much better way. In comparison, in the GCB patients, as we've seen here, they may associate with BCL2 MYC translocations. They are different animals. So in the initial NIH-driven trials in MCD N1 patients, you were seeing here adding on BTK inhibitor may improve patient survival, but not in the GCB patients. Now, this early trial still need to be validated. So MD Anderson did smart trials confirming BTK inhibitors might be beneficial in subset of patients, but these studies maybe require a further verification. The reason is when we look in the NGS profile in DLBCL, 37% patients we cannot classify. So even 63% patients can classify based on the cell origin and mutations into 7 subtypes. 37% patients cannot be classified, raising a questions now. Targeted therapy by using different chemotherapies or small molecules may have limitations, suggesting CAR-T and bispecific antibody or ADC may play a more important role in our future clinical practice. Also emphasize in our pathology practice, we may leading into, besides the pathology evaluation, we also need to emphasize targeted NGS sequencing may help us to stratify patients into different subtypes. So I suggest maybe, for example, with a double hit, with a single hit, single express, or patient with a particular other genetic aberrations, or with p53 mediated. And those patients may respond to different treatment regimens based on treatment response. Besides of lymphoma cell genetic changes, we have already missed a major component regarding the microenvironment. So in the future, by using multiplex spatial panels, we're able to analyze many biomarkers in a single slide, and combined with genetic results, able to providing us to our hematology oncology colleagues to design a better treatment. So let me summarize my first presentations. So DLBCL is a malignant B-cell lymphomas arising from B cells that may carry different clinical pathology phenotypic features. The combination treatment in the first line, based on treatment response, paved the way for the second line and third line treatment decision. What we learned in the past will help us prepare better for the future. So for every single DLBCL diagnosis, we emphasize the location, pathology, family histories, precision classification, genetic features, and maybe environment features also in the future. So when we look at the DLBCL, every year we see 12% increase in the United States, 7% increase in the West Europe. And based on the cell origin, may be insufficient now to providing our clinical colleagues for a better decision-making process. We have to integrate with additional biomarker and the signaling for the clinical decision. In subset of patients may containing high-risk genetic changes, including double hit, double express, or p53 mutations. And those patients may need to handle in different ways. NGS, particularly targeted NGS sequencings, may providing us with additional information, may potentially help us for future treatment decision. However, the challenges still remain in the DLBCL field regarding improved or adequate testing menu for particular biomarker. How are we going to monitor patients' MRD or adverse event monitoring and prognosis? So we emphasize the multidisciplinary efforts, collaboration, besides of the pathology, targeting most common disease, but also rare uncommon type, and collaborate with our hematology colleagues for clinical research application, radiation oncologist, and maybe in the future from central hospitals into community hospital, monitoring patient not only in the other clinical settings, but also in the community setting as well. So finally, I would like to bridge in this slide from my presentation to Dr. Chihara, and he's going to present us with most recent advance, how we handling patient from first line, moving into the second line and third line. And each of those process that we need to perform a biopsy on the patients, analyze the biomarkers, and those biomarker expression may pave the way for ADC, bispecific antibody, and CAR T therapy regarding the antigen sensitivity or antigen loss, and maybe other companion tests going to moving into the future. So let's go back to the questions. Based on all those selections, as we see here, the A will be the best option because teach us regarding the cell origin, regarding the double express, teach us about the proliferation index that correlated with molecular and genetic changes. Thank you so much. Let me stop in here and transfer to Dr. Chihara.
Okay, wonderful. So we're gonna go from the case. So this is a 60 years old fit patient with non-GCB large cell lymphoma. This patient had a high risk disease, stage 4 IPI score of 4. 3 months post polar-RCP as a first-line treatment, this patient had a progression. So which treatment do you choose? A, oxycaptogene chloruloso, B, tafasitamab lenalidomide, C, R-GemOx, D, glofitamab, E, bendamustine, not bendamustine, brentuximab vedotin plus R square, and then F, tisagen locurso. Please vote. Okay, I think we had a vote, so we're gonna talk about how we select these all new agents that are available today. Nice to meet you. My name is Dai Jihara. I'm one of the lymphoma faculty at MD Anderson Cancer Center, working on clinical investigation in B-cell lymphoma. So today, the title of the talk is Discuss Novel Therapies such as antibody drug conjugate, CAR T, bispecific antibody, and combinations for relapsed refractory large cell lymphoma. So I won't spend too much time on this slide, but this slide shows the current NCCN guideline, which lists 3 standard first-line treatment options for our large cell lymphoma, R-CHOP, polar-RCHP, and those adjusted EPOCH as listed here. Although we don't yet to have a definitive criteria or a biomarker to help us select one regimen over the other, in general, about 65 to 70% of the patients are cured with first-line therapy. As Dr. Young mentioned, in general, we use dose-adjusted EPOCH for double-hit lymphoma patient, and then we tend to use polar-RCHP for ABC large cell lymphoma, as shown in Parallax trial. But unfortunately, the Hans that's available immediately or readily in clinic is not the representation of the gene expression profile-based classification. So there remain a huge challenge in how to select these regimen for first line. This slide shows what typically happens after first-line treatment for large cell lymphoma in patients who experience progression or relapse later. So the data from Swedish lymphoma registry showed that about 70% of the recurrence occur within the first 2 years, if it happens. And then that late relapse are quite rare. So post 5 years, it's only 6% of the relapse that happens. The Goya trial demonstrated that among patients who achieved complete response at the end of the first-line treatment, only around approximately 15% eventually experienced the relapse. This slide summarizes the treatment approach we used about 5 to 10 years ago, before the introduction of many of the new agents available today and that I'm going to discuss. At that time, patient received first-line anthracycline-based chemotherapy. If the disease recurred, the standard was second-line chemotherapy with platinum agent. For those who luckily achieved a complete response and then were eligible for transplant, the next step was auto transplant. as a consolidation. However, in real world practice, this applied to only about roughly 10 to 20% of the patients with relapsed refractory disease, as many were not candidate for transplant due to age, comorbidity, or chemo-refractory disease. So over the past 5 years, the treatment landscape for relapsed refractory large cell lymphoma has changed dramatically. When we think about second-line treatment, there are two key factors now guide our treatment approach. So one is the timing of the relapse, whether the relapse occur within 12 months of initial therapy or after 12 months. And the second one is, are the patient eligible for transplant or CAR T-cell therapy? So this slide shows the current NCCN guideline for patients who relapse within 12 months. If they are eligible, these patients should proceed directly to CAR T-cell therapy with or without bridging treatment. If they're not a candidate for CAR T, which is hard to define who those are, but if they are deemed not eligible for CAR T-cell therapy, it's a very complex assessment than transplant eligibility, but if they're not CAR T eligible, then the bispecific antibody combination, such as glofitamab GemOx or epcoritamab GemOx or even mosunetuzumab, are appropriate. And then these are now as option in NCCN guideline. This slide shows the current guideline who experienced the recurrence more than 12 months after completing the first-line treatment. For fit and transplant eligible patient who achieve a good durable remission from first-line treatment, first-line chemotherapy, I think it is still reasonable to consider second-line chemotherapy followed by auto transplant. However, I think many of us are now leaning towards exploring newer treatment options, such as CAR T-cell therapy and bispecific antibodies, even in this later relapse setting. The key question remains whether the patient's disease, the lymphoma, is still chemosensitive or if they are chemosensitive or not. But unfortunately, we cannot determine that until after we start the chemotherapy. So that remains the challenge of these late relapse patients. Although these data are now somewhat outdated, as you all know, 3 randomized phase 3 trials were conducted to compare CAR T-cell therapy with the standard of care in patients who relapsed within and then were eligible for transplant. So the ZUMA-7 tested Axi-cell, Belinda tested Tisa-cell, and then Transform tested Lyso-cell. These ZUMA-7 and Transform demonstrated a significant improvement in outcome with CAR T-cell therapy compared to standard treatment, which was second-line chemotherapy followed by transplant at that point. In contrast, the Belinda trial, which is in the middle, with investigated Tisa-cell did not show a survival benefit, partly due to longer manufacturing time and then greater use of bridging chemotherapy, leading to disease progression before CAR T-cell infusion in this trial. It took close to 2 months to manufacture T-cell outside the United States, so that impacted the overall outcome of the study. With the longer follow-up data, the ZUMA-7 trial has now demonstrated an improvement not only in progression-free survival, but also in overall survival with CAR T-cell therapy compared to standard chemotherapy followed by transplant approach. Given these results, it's becoming increasingly difficult to justify using chemotherapy as a second-line treatment for patients who relapse early. In ZUMA-7, patient randomized to standard of care arm were allowed to receive CAR T-cell therapy in third-line setting after progression. However, only 57% of patients were ultimately able to receive CAR T-cell therapy. So this highlights critical point that if we don't move towards CAR T-cell therapy early, we may miss the window or opportunity to screen and then treat patients while they're eligible. And ultimately, if we don't send the patient CAR T quickly enough, we may be compromising the outcome because they're not receiving the most effective treatment by taking too much time for us to screen patient for CAR T. Now, what about the patient who are not eligible for transplant? So that question wasn't directly addressed in the 3 randomized phase 3 trial that we just reviewed because all patients needed to be transplant eligible to be eligible for these trials. However, there was a single-arm phase 2 study evaluating liso-cel as a second-line treatment or later therapy in transplant-ineligible patients. As shown here, the outcomes were comparable to those seen in other CAR T-cell studies, including similar response rate and then survival curve. Importantly, this trial also included patients who relapsed after 12 months, suggesting that CAR T-cell therapy remains a reasonable option even for those with late relapse who are not candidate for transplant. Bispecific antibodies are now moving into the second line, and I would like to introduce 2 trials evaluating their role in the second line setting. So the first is the STAR-GROW trial, random phase 3 study for patients with relapsed refractory large cell lymphoma who have received at least 1 prior line of treatment. For patients who enrolled in the second line setting, eligibility, the patient needed to be ineligible for transplant, because if they are eligible for transplant, they probably should go to CAR T directly instead of enrolling to this clinical trial. So in this study, patients were randomized to receive either 8 cycles of glofitamab plus GemOx followed by 4 cycles of glofitamab monotherapy, or 8 cycles of R-GemOx as a control arm. So this slide shows the response rate from the STAR-GROW trial. And then as you can see, there's a clear difference between the 2 treatment arms. The overall response rate with glofitamab GemOx was about 70%, and then the complete response rate was approximately 60%, which is quite impressive for the relapsed refractory large cell lymphoma in this setting. And then you do see a clear difference in response rate between these 2 arms. So in addition to higher response rate, patients who received glofitamab GemOx also demonstrated a significantly longer progression-free survival. So the median progression-free survival from glofitamab GemOx was about a year, 12 months, compared to only 3 months in the R-GemOx arm. You can also appreciate the plateau in the progression-free survival curve even after treatment completion. So the R-GemOx, they basically completed 12 cycles of the glofitamab. Takes about 9 months to complete. So beyond 9 months of the treatment, they have not received any treatment. And then when you look at the survival curve, even beyond like 2 years after completion of the treatment, they are still in remission. So, this is very encouraging result, and then suggests that some patient may achieve durable remission, potentially cure from bispecific monotherapy or combination. This is the main side effect of the bispecific antibody, cytokine release syndrome. As you all know, that cytokine release syndrome was manageable. The pattern was very similar to single agent glofitamab. Most CRS events occurred during the first dose, so cycle 1, day 8. And then the majority are grade 1. So typically presenting just as a low-grade fever and then well-controlled with the supportive care. I think we have low threshold of giving corticosteroid for patients with CRS receiving bispecific antibody. So 50% of the patients did receive steroid for the management of CRS. The rate of the CRS seems to be a little lower than the single agent glofitamab. So we think that if you do combine chemotherapy with the bispecific antibody, it may lower or reduce the chance of patients spiking fever or having CRS by tumor debulking. The next trial is a SUMO trial recently published in JCO. The design of this trial is very similar to STAR-GROW, but with some key differences. So it compares mosunetuzumab polatuzumab to R-GemOx, And then importantly, included not just large cell lymphoma, but also transformed follicular lymphoma, high-grade B-cell lymphoma, and then grade 3B follicular lymphoma. In the mosunetuzumab polatuzumab arm, mosunpola arm, patient received a combination therapy for 6 cycles, followed by 2 additional cycles of mosunetuzumab monotherapy, for a total of 8 cycles. And then for R-GemOx arm, it's the same to the StarGrow trial. They received 8 cycles of R-GemOx. So the slide shows the response rate from the sumo trial. And then again, you can clearly see a difference in response by the treatment arms. So in the mosunetuzumab polatuzumab arm, the overall response rate was approximately 70%, with a complete response rate of about 50%, demonstrating the strong activity of this non-chemotherapy bispecific ADC combination. And then what's intriguing and important for us is that the response rate of R-GemOx in the sumo trial is very similar to what we see in StarGrow trial, showing that, this is what you get basically from sending patient to R-GemOx or the most likely very similar chemotherapy regimen in relapsed refractory setting in large cell lymphoma. So this slide shows the progression-free survival. Interestingly, the curve looks very similar to what we saw in StarGrow trial, even for the progression-free survival. And again, showing a clear improvement with mosunpola compared to R-GemOx. The data reinforce the consistent benefit of bispecific antibody-based combination in the second line setting for patients with relapsed refractory large cell lymphoma. And then there is also one trial, single-arm phase 2 trial testing epcoritamab GemOx. That trial also showed a very similar outcome by bispecific antibody combined with the GemOx. So these became available in NCCN guideline. As many of you know, the CRS associated with mosunetuzumab tend to be easier to manage compared to glofitamab, and then that reflected here in the table and figure. In this study, fewer than 10% of the patient required tocilizumab or steroid, indicating that most CRS events were low grade and then very well manageable with supportive care alone, either just Tylenol or just let patient tough it up. So with all these new studies, the management of relapse refractory large cell lymphoma after first-line treatment has become much more complex, and we now need to carefully consider the timing of relapse refractory disease. For patients who relapse within 12 months, I think it's almost a no-brainer. We should prioritize a pathway towards CAR T-cell therapy as early as possible. And then for those CAR T-cell therapy, unfortunately, due to building the trial, we don't screen patient for T-cell. It's for axi-cell and lysocell. And then even for those patients who relapse after 12 months, the field is clearly shifting towards away from conventional chemotherapy like R-GemOx. There are multiple studies showing that R-GemOx is unlikely to be the standard from now on, based on the StarGrow, sumo, and an EPCOR trial. In this setting, bispecific antibody combination, and then even like CAR T-cell therapy for those who are not eligible for transplant. In selected cases, they should receive this bispecific combo or consider for CAR T-cell therapy. Now moving on to third-line treatment and beyond. Of course, the CAR T-cell therapy and then bispecific antibody remain important option for patients who have not yet received them until third-line treatment. However, there are also several other agents that can be considered as listed here: brentuximab vedotin R-square, loncastuximab tesirine, or selinexor. Let's quickly just review the pivotal bispecific single agent studies, starting with the glofitamab, because I think it's still very important to have that single agent as an option. In its phase 2 single-arm single-agent trial, glofitamab was administered intravenously for 12 cycles with a weekly step-up dosing schedule. The study showed an overall response rate of about 50%, and then a complete response rate of around 40%. I think what's particularly intriguing for us was that some patients have remained in durable remission for more than 3 years after completing the treatment. Now, very similar to what we saw in SARGROW trial, but even with the longer follow-up. And then this is not indefinite treatment. This is a time-limited treatment that patient finished treatment around this time. There are patients that who remains in durable remission, suggesting that bispecific antibody may offer the potential for cure in a subset of patients. Epcoritamab was also evaluated in phase 2 trial, which demonstrated an overall response rate of 60%, and then a complete response rate of around 40%. The key difference between epcoritamab and glofitamab lies in their route of administration and in schedule. Epcoritamab is given as a subcutaneous injection and is continued until disease progression or until intolerable toxicity, rather than for a fixed number of cycles like glofitamab. As you can see from the survival curve, many patients who achieve complete response can remain in long-term remission, suggesting durable benefit even with ongoing therapy. So the brentuximab vedotin CD30-directed antibody drug conjugate with the payload of MMAE was evaluated in combination with lenalidomide and rituximab. We tend to call it R-square in the phase 3 echelon 3 trial. This study enrolled patients with relapsed refractory large cell lymphoma who had received 2 or more lines of treatment. Importantly, CD30 expression was not required for the eligibility. They did use CD30 expression level for the stratification of the randomization. The primary endpoint of the study was overall survival. So the echelon 3 trial showed that the VBR square combination achieved a higher response rate and a significantly longer progression-free survival and an overall survival compared to R square alone, met the primary endpoint of the study. Based on the results, VBR square was approved by FDA for patients with relapsed refractory large cell lymphoma after 2 or more prior lines of treatment. Interestingly, the benefit was observed regardless of the CD30 expression, with patients who were negative, CD30 negative, also responding well to the treatment. So the complete response rate for CD30 negative patient was 40%, which is not different than those patients who had CD30 expression. I think the major challenge or the criticism for this trial is that R-square is not necessarily a standard treatment for relapsed refractory large cell lymphoma. So there is some challenge of interpreting the results. However, I think it is still a very good treatment option for a patient who relapse post like CAR T and then bispecific antibody. Another non-chemotherapy options is a combination of tafasitamab and lenalidomide evaluated in the LMIND study, single-arm phase 2 trial. Important points to note in this trial is that the trial excluded patients who had primary refractory disease. This distinction is key when interpreting the result, as the study population generally had less aggressive disease course or biology. So as you can see here, the complete response rate with tafasitamab lenalidomide was about 50% in the second-line setting, listed here. And then these complete response can be very durable, as shown by the blue curve on the survival curve. This regimen works particularly well for patients with a more indolent course of aggressive lymphoma. And in my practice, I tend to consider tafalen for frail patients who have late relapse, like beyond 2 years, or when I'm hesitant to pursue CAR T or bispecific due to comorbidities or overall condition. Loncastuximab tesirine, a CD19-directed antibody drug conjugate with the PBD dimer as a payload, was evaluated in the single-arm phase 2 trial for patients with relapsed refractory large cell lymphoma. Again, Lonca T demonstrated a good clinical activity with a complete response rate of about around 25%, and then many of these complete response were actually durable, as shown in the figure. This agent has also been evaluated recently in combination with bispecific antibody, such as glofitamab in the LOTUS-7 trial. It was just presented recently. It showed really high response rate. I'm very hopeful that we can start considering this like bispecific antibody plus ADC like Lonca in the near future. And then so stay tuned. I believe Lonca will continue to play an important role, particularly in the combination regimens in the future treatment landscape of relapsed refractory large cell lymphoma. Going back to the case, so this patient had an early recurrence after first-line chemotherapy and then experienced early disease progression. So given this course, we did select Axi-cel as a second-line treatment, supported by the ZUMA-7 trial data. Unfortunately, the patient progressed after CAR T-cell therapy. So what do we do next? The treatment choice can be liso-cel as a CAR T, tafalen, R-GemOx, glofitamab, efgartigimod, mosunetuzumab, BVR square, Lonca T, or tisagenlecleucel. Please vote. So for this case, actually most of them are correct answer. I probably wouldn't use tafalen because of the refractoriness of the disease. So these aggressive large cell lymphoma, I probably wouldn't use tafalen as a choice. And in R-GemOx too, we already know that the R-GemOx in this setting is inferior to bispecific or the bispecific combination. So I wouldn't use these two, tafalen or R-GemOx, but everything else can be an option. So moving on to the next case, this is an 82 years old unfit patient who received our mini job as first-line treatment and then experienced disease recurrence after 2 years. So what do we do in this situation? So the option one is liso-cel as a CAR T, tafalen, R-GemOx, glofitamab, efgartigimod GemOx, mosunetuzumab, or tisa-cel. Please vote if there's some polling. I don't know if the polling is coming up. So for
There's no poll on this one.
Okay. All right. So for this patient, I will likely avoid CAR T-cell therapy, given the patient age and frailty, and then I would also prefer to avoid traditional chemotherapy like R-GemOx, trying to avoid the toxicity from it. So instead, I would consider like mosunetuzumab based on the sumo, or even for tafalen. So this is the patient population that I would consider tafalen based on the L-MIND study. Another reasonable approach could be a bispecific antibody combined with GemOx, depending on availability and patient tolerance. If I think they can tolerate handle chemotherapy, these can be an option. So in conclusion, CAR T-cell therapy has become the standard second-line treatment, particularly for patients who experience early progression after first-line treatment. However, this treatment is not yet reaching all eligible patients, and in access and in utilization remain a major challenge that need to be addressed. Bispecific antibodies are highly active agents, both as a monotherapy and in combination, and are now moving into earlier lines of treatment. It will likely come to first-line treatment soon. In addition, other effective agent options such as BVR square and Lonca T continues to play an important role in the management of relapsed refractory large cell lymphoma. And with that, thank you all for taking the time to meet with us on Saturday morning. I truly appreciate the participation, and I'm happy to answer any questions you might have. Yes. If we're done?
Yeah, Yeah, the first question regarding what is the essential biomarker and the which study should be done on the primary DLBCL patients. I think that there are essential immunobiomarkers you have to perform, including T cell mark CD3, B cell mark CD20, right? So those are the two you have to see. If we say there's no flow cytometry performed, only based on immunostains, then you need to perform on CD10, BCL6 MUM1 for the GCB ABC classification. I always add on KR67 to measuring the proliferation index. So those 6 markers are essential, basic. Then alternative one, you may add on with including EBV CD30 because there's BV trials, right, confirmed by FDA, approved. Then you have other markers, for example, with MYC, BCL2, PV3. Those are alternative optional based on the patient clinical scenarios. For if a patient is immunocompromised, they are always add on EBV staining. Now, if double express is a critical ABC subtype previously, then you need to think about if a patient has a previous history of follicular lymphoma, marginal zone, then you need to think about additional biomarker as well. So for FISH analysis, measuring the translocations, MYC BCL2, BCL6 is essential. You have to do it for every single DLBCL patient. I always add on PV3 as well, because PV3 mutations and deletions also associated with primary resistance or early relapse as well. So those are probably the essential one. Thank you for the question. Yeah, go ahead. I have another question, I think, for Dr. Cheheda here.
So should I answer my case or this question posted? So going to the case, it was a young, fit patient who were eligible for transplant and then had a very short remission duration post first-line treatment. So at this point, I think the standard treatment or the standard approach for such patient is CAR T cell therapy. So the choice number 1A, axi-cel, is the right answer. We don't send them to chemotherapy, and then we don't send them to like tafalen because they were not the patient who were tested in L-MIND study. I think the challenge for us, which is also posted in the question, we don't have the data of comparing CAR T versus bispecific in the second line setting. So we don't have the answer to that question. I do still tend to send a patient to CAR T if they are eligible. You can't really compare trial to trial, but when you think about how much patient can in remission post like completion of the treatment, it's roughly around 40 to 50% by the CAR T. Only about 40% or 40 to 50% of the patient can achieve complete response by the bispecific monotherapy or combination, and only about 60 to 70% of the patient can remain in durable remission if they do achieve complete response. So when you do some math there, likely the portion of patient who can be in durable remission, potentially be cured by bispecific, at least at this moment, will be lower than CAR T is what I'm thinking. So I do prefer CAR T over bispecific combination in large cell lymphoma as long as they have option to go to CAR T. I think that access utilization of the CAR T is the major problem now. In my opinion, it is underutilized as a treatment because it is hard to access with the various reasons.
Dr. Cheheda, they have another question here is now, if a patient relapse in 10 months, you will not send for SSL CAR T. Instead, you're going to treat it with glofitamab, GMAS. What kind of choosing this?
Yeah, so I think that's what like StarGrow and then all the second line bispecific combination has tested. If they're not eligible for transplant, and I think at this moment, I think I don't really consider transplant eligibility. I do consider as a CAR T eligible or not. If they're eligible for CAR T, I still send them to CAR T. Probably if they're frail and then can't even be eligible for like liso-cel, then I would consider these early progression for bispecific combination. But usually, probably I'm biased, working at MD Anderson, but I do tend to screen all patients for CAR T as much as possible.
Have an age limit for CAR T and bispecific antibody?
We don't really have age limit at Anderson. We have treated a couple 80 patient, like age of over 80 at Anderson. It's not Axi-cel. We tend to use liso-cel for these patients. So age is not the cutoff. Like chronological age is not the cutoff. I think the functional status is the key here, and then it is hard to assess that accurately. So we started some program at Anderson to understand who have not just the mortality, but like the morbidity from the treatment, and try to screen patient better for this intense treatment.
I see. May I have a question about patient with p53 mutation or deletion or biallelic p53 mutation in DLBCL patients? How are you handling those patients? And those are commonly presenting with poor treatment response and primary resistance to the first.
Like, question to me?
Yeah, question to you.
I actually want to ask that question to you. So I do have a patient right now in my clinic who have TP53 mutation. He also have 100% overexpression of P53. He hasn't responded to anything that we gave, including chemotherapy, CAR T, bispecific. So we're now trying Viper, the NCI regimen, venetoclax, ibrutinib, lenalidomide, pembrolizumab, and obinutuzumab. So we just started. I don't know if he's going to respond. The short answer to your question that I don't think we know what works for this very aggressive large cell lymphoma, and then I do want to put patient on trials, testing a new mechanism of action, including like BCL6 degrader. We just haven't had any window to screen him for the trial because it has been really aggressive and then explode pretty quickly. Thank you very much for attending, this conference and Saturday morning. I truly appreciate, we truly appreciate your attendance. Thank you.
Thank you.